Paul Heinrich is here and Ambassador is here. We're getting ready. We're going to be starting in about 1 minute. And welcoming everybody who's rapidly tuning into our latest webinar. How is everybody doing today?
Oh, I think we're going to be, Bob, I know over here, we've checked out our equipment and it's working well, as opposed to yesterday. We had a rehearsal, we had some problems. So speaking for the four of us here, I'm pretty happy that we've got the technology problem solved.
Yeah. Yep, and we're here in North Bay, and we're very excited to be participating in this webinar today. We're very proud of what's happening in North Bay Regional.
Excellent. Well, we're at noon hour, so if we can hit the record button, I'm going to do a quick intro, and then we'll get started. So, okay, a little bit of housekeeping. It's my pleasure to welcome everyone to today's webinar. A big thank you to everyone for registering and tuning in. We know how busy people are, and we really work hard to keep these events interesting and on target. We do encourage questions, so please use the question and chat tools in your webinar console. I'll be monitoring and collecting them for a question and answer discussion afterwards. And one housekeeping item that's it's been a problem the odd time. If you're calling in, please mute your microphone on your computer so we don't get any background noise. Anyway, about our speakers. Ambassador really needs no introduction. He founded Ambassador Applied Creativity more than 30 years ago. He started his career at Procter & Gamble, where he received 3 U.S. patents and created a corporate-wide internal consulting practice. Following his award-winning doctoral research at the University of Cincinnati, Min became a professor of management in the Michael G. DeGroot School of Business at McMaster University. He continues to consult around the globe and teaches in the Executive Education Program for Aalto University, as well as the Innovative and Creative Problem-Solving module at the Conference Board of Canada's Directors College. Min's latest book, titled Design-Centered Entrepreneurship, is now available on Amazon. It's already been nominated as a CMI Management Book of the Year award in the UK. Paul Heinrich serves as the Chief Executive Officer and President at North Bay Regional Health Center. Paul has been the CEO and Vice President at Foundation of Chatham Kent Health Alliance. He served as the CEO and President of Georgian Bay General Hospital until 2014. He served as an Executive Director and Chief Financial Officer for the Faculty of Medicine at the University of Calgary since 1998. He's also served as an advisor to the Chief Clinical Officer of the Calgary Health Region. And prior to working in Alberta, he held senior administrative positions at the Huntsville Hospital and Muskoka Community Care Access Center, as well as the Inuvik Regional Health and Social Services Board in the Northwest Territories. He serves as ex officio Director of North Bay Regional Health Center and served as Director. Dr. Donald Fung is the Chief of Staff and Vice President, Medical Affairs since 2013. He is a full-time staff anesthesiologist who trained in Toronto and came to North Bay as a locum in 1987. He holds a Master's of Science in Health Administration from the University of Toronto, and Dr. Fung has held multiple administrative positions as Medical Director, Surgical Care Center, Medical Director, Clinical Utilization, and Critical Care Director. Today, we're really excited to be joined by our 2 guest speakers who are going to share some first-hand examples of using Simplexity thinking to drive innovation in their healthcare facility. More specifically, we're going to dive into some real case studies involving physician-led problem-solving and leadership that have made a real difference. Thank you again for tuning in. We hope you enjoy the webinar, and I'm going to turn it over to Min, Paul, and Dr. Fung.
Thanks, Bob. And I'm going to go to the next slide. One thing I wanted to say is we're going to try to reserve as much time as possible for the work that's being done.
Muted.
Many of you have tuned in before. Some have not. I'm going to cover the basic idea about the Simplexity thinking, how it got, but there's some fascinating ways they've adapted the process and made it work, which I want to leave plenty of time for. Quickly, how did we get to North Bay? Unusual. And as usual, discovering problems that are important is the key to innovation, and that's what's been done a lot in Paul's career. And then how do we engage staff and physicians? Candid discussion and get consensus. Meet the needs, the time needs. The hospital's a very fast, busy place. How do we integrate this problem-solving approach into our daily business, not just once in a while? And we're going to have a lot of first-hand examples of how it's been used in the real world to help better patient care and better, more efficient hospital care. And then what have we learned? Now, the innovation, the definition we like, it's people. It's breaking down the barriers, tapping into creative minds, and working collaboratively together to make use of existing resources to improve services and outcomes for patients. That's the definition of innovation that we like in healthcare. There's lots of others that work on what did we accomplish, but this is how we accomplish stuff. It's people-oriented. And this is a view of North Bay Regional Health Center where Paul and Dr. Fung are. So, Paul, why don't you say a few words about it?
Okay, so we're a very interesting organization. There were two former organizations, one that was a specialized mental health care organization and the other a large community hospital. And in 2011, we moved into brand new, beautiful space together, and we also became a merged organization to form North Bay Regional Health Center. So we have all manner of mental health services that serve the entire Northeast region, including mental health and the law. And we have a very busy emerge and it's a large community hospital, so it serves both. And we coexist together. And one of the exciting things is we've reduced the mental health stigma that was a real concern right around the merger. And now we coexist with all manner of patients that are served in under one roof. We have over 2,000 employees and over 150 physicians with active privileges.
Very good. Okay. Now, what's happened is Simplexity skills have been built at North Bay, but where did it all start? The Directors College. As some of you know, our university with the Conference Board of Canada has a Directors College where people come 3-4 times a year and in about a year and a half graduate in something called innovative and creative problem solving. These are all people who are either directors of companies, organizations, or are aspiring to. And that's where I met Paul way back around this time, and off he went, and I heard from him about a year later. And he was at the Calgary Faculty of Medicine, and he contacted me saying, we might need some help in creative thinking about how we might best support communications and media relations for the Faculty of Medicine. So I went, we had a very successful time engaging a lot of people and coming up with some very good solutions. Well, 2009, I got a call from Paul, and he was at the Ontario Chatham-Kent Health Alliance as a vice president. Now he said, you know what, we can sure use some help on how might we get ourselves back on track in meeting our annual financial goals with high performance. So I would go, and then we would have a very good session and develop some real action plans, and then I wouldn't hear from again for another year or so. And the next time was from Georgian Bay, which is north of Toronto, not exactly as far as North Bay, but he called about how might we get more high priority projects done well and on time. And at this time, I think, Paul, I'd like you to say a couple of things about this challenge.
Right, and it was after that, all those great experiences, and as I was contemplating my new post in North Bay and making my way towards North Bay, I reflected and realized that each of those engagements that were very helpful with your support, Min, we solved a single problem. However, I started to think about how might we enhance our organization's ability to continuously find good problems and solve them, and do it also hand in hand with physicians. That's a teaser.
And yeah, and that led us up to North Bay, and as you can see, problem finding is the key for innovation. That's the first step in our wheel, and good organizations don't wait for problems. They're unearthing them. They don't bury them, put them under the rug. They don't say, well, that's a problem for somebody else, but in my division, we don't do that. They work on finding problems and attacking them. And often they're the ones that are in between the crack. Almost nobody seems to own them. But it's very important that the top person He's a good guy who finds them, or good girl. Everywhere Paul's been, he's been a problem finder. He gets things started, and he gets people engaged in making things better, and that's why we like working with him so much, and North Bay was no exception. Now remember, the innovation wheel, this will be new to a few of you, has 8 steps in it, starting with problem finding and ending in action, and people have various likings for different parts of the wheel, and generators, conceptualizers, and optimizers, and implementers all like different parts of this wheel, and a trick becomes for them to respect each other and help each other work their way around where they find problems, define them, get best solutions, and implement. Now, there's another reason why people shy away from change. They don't like the word problem. We have terrible words for the word problem: negative, stalemate, roadblock, obstacle. If this is the way you're looking at the word problem, why in the world would you ever want to start the process that starts with problem finding? On the other hand, there's lots of very positive words for the word problem: growth, opportunity, challenge, goal. Yeah, we got a goal to meet, but how are we going to do it? It's going to require creativity. Our budgets are being cut. How do we meet our goals? It's all problem finding and problem solving. And if we start looking at the word problem as a positive thing, no matter what, we're going to get the wheel rolling toward innovation. And that's what's happened in all this work that we're talking about. Now, leadership. Another word for what we're doing is called leadership. When you're making change and things happening, you're leading. Now, this is a seminar I went to. I belong to the Procter & Gamble Alumni Association. It was a great company I learned from. And 500 of us alumni were in attendance with a roundtable with the presidents of eBay, 3M, General Electric, and Procter & Gamble. These 3 people had used to be at Procter & Gamble's managers, and now they had ascended to the CEOs of their companies. The roundtable leader said, "What's leadership in the 21st century?" Without hesitation, the answer was driving change. Are you able to drive change, make things happen? It doesn't matter whether you're tall or short or fat or what your personality is. Can you drive change? It's as simple as that. Then, number 2, are you able to develop new leaders who can engage others in driving change? They may not have authority over them, but they can spark change. And I'm thinking, boy, that was an interesting session I was in. It made me feel a lot better of the work that I was doing, which is largely leadership. Yeah. Now, how was Simplexity rolled out inside North Bay?
Man, I just wanted to speak to that last slide briefly. Can you just go back one? Yeah. I just wanted to reflect on that, Min, and build on what you were saying. You know, a leader can be have an autocratic style, but when you try to drive change in an autocratic fashion, it doesn't necessarily stick. So the idea is to use Simplexity to drive change, but while getting buy-in. And obviously, to reinforce what I said earlier about North Bay, how do we make this part of our culture, part of our toolkit? And some of the things we're doing is ongoing training in Simplexity, continuing to identify good problems to solve using the tools, and constantly reinforcing this type of thinking process, because there's always the presence of killer phrases, which you'll come back to later.
And you know what? What it does is it makes problem solving fun. People do like solving problems when they get a chance to use their brains and feel comfortable. They actually like solving problems. So engaging people, as you said, is absolutely critical to achieve this kind of innovative thinking. And now at North Bay, here's what happened. The process always starts with an open mind. Paul's not going to say, come on up and do something to us. What we do is Simplexity means with, hey, thanks for finding something. Let's come up and have what we call a pre-consult. And the pre-consult takes you through the first 3 steps. And it's largely problem definition. What is it that North Bay would like to accomplish? And you do this with the top 2 or 3 people in the organization. And that led to having a pre-consult on October 2, 2013. And Paul invited a group, and lucky, wow, we lucked out, and these were problem finders. These are all people largely generators. And if you want to find out what problems we're having, we were lucky enough to get the people who do enjoy problem finding, and they came to the session, and we had the small group do problem definition. And Paul, you jump in anytime, but I kept this documentation very interesting.
Yeah. I wanted to just say that that's reflective of the senior team. Later on, you're going to show a scatter diagram of our whole organization. So it's really good we had problem finders, but if we just had only that and no way of implementing or engaging the team, we wouldn't have gotten very far in the process, right? Because creativity, by definition, means you have to actually accomplish something, as you always teach us.
Absolutely. And interesting enough, that the senior leadership team, that's a big job of theirs, which is not to provide solutions to people, but discover the problems that need to be solved and then engage the organization in doing that. Now, here's the challenge map we came up with. Now, I don't want you to try to read all this, but I'd like you to look at the top. How might we increase revenue for the hospital? That's very strategic. How might we become a recognized center of learning and academic achievement? How might we become the most sought-after people hospital? Now, as you work your way down and say what's stopping us, we ended up with these three colored challenges. How might we empower our people to find and solve the right problems? How might we add this thinking, this fuel to our training program? And bottom, how might we get 5 medical directors and 15 administrative directors to learn creative problem solving on real problems? So these are the ones we picked. They're repeated here. And we said, you know what? If we get going on this, this is a toehold for us to get people engaged in what we're hoping will happen here. And several problem-solving sessions were planned to accomplish these 3 selected challenges. One was, how might we become a truly effective integrated leadership team? That was picked as a key problem to attack, and we did. And we came out with action plans that were implemented. Another one was during the Medical Leaders Day, current and future Medical Leaders Day, how might we become better leaders through improving communication, cooperation, and conflict resolution between physicians and within and across medical departments? Carefully thought out. And then we had a major workshop with the extended leadership team, 35 people engaging everyone, and we had an excellent session to prepare us for where we were going. We documented the learnings after mapping and defining the problems. We generated ideas and action plans. We came around the wheel, so to speak. And this was the challenge map that we developed. Again, only a few key ones. At the very top, how might we achieve superior patient care? That's something that everyone is going to buy into. How might we improve the health of the community? How might we achieve better patient outcomes? No matter what we're doing, if we keep on asking why, we want to make sure it's heading toward those goals. The biggest one we came up with was, how might we increase collaboration between administrators and physicians? That became that little nugget, or that logjam log that we had to pull. Paul, you okay with this here, and fits with what you remember?
That's right, and I want to reinforce, and we're going to talk a little bit, I think, later on about telescoping, but this is that second part of creative problem solving is the convergent thought. And so here we highlighted the one that we're going to work on, and that was how might we increase collaboration between administrators and physicians. So everyone had to, you know, even the quiet people and the talkative people, everyone had to contribute in a way that was very equalizing, and the process does that, and that's one of the wonderful attributes of it. So on the next slide, I talk about some of the action plans then that arose from that how might we. And what we ended up doing in North Bay that came out of that original work, we defined a consistent admin day for our medical leadership. In our structure, the people who have credibility as clinical leaders also have to do clinical practice. And so we have part-time administrative folks, but we had to really, Dr. Fung had to insist and make sure that we had consistent days so we could behave as a full team with all the different departments and between admin and the docs. The other thing we did was co-locate our medical leadership with our senior admin, and we did have some free space as we got more efficient financially. We actually freed up some space, and we reinvested that to create really nice interactive spaces with our docs. So we're always running into each other in the hallway. We're solving problems all the time, identifying problems all the time, and interacting. That's key. And we have now become, it's almost second nature, and I think it's so rewarding to be able to speak about this today, because there's been a number of years we've been doing this, and you sort of make it become so much part of what you do that you really don't celebrate it enough. But we're really taking the most challenging fuzzy situations or potentially divisive challenges that we would normally be worried about tackling. We're now using creative problem solving to address those stickiest of problems. And it ends up being fun and collaborative, and we don't have very many tense moments as we work through that. That's pretty powerful. We've collectively prioritized projects and initiatives through visual management tool. You're seeing one wall in what we call our strategy room, and it's very small for the participants. However, it's reflective of a mental health column, a corporate column, a clinical services column, and a medical affairs column. And we visually share what's our top priorities. We collaborate across the columns. But the key is that the actual medical leaders are interacting with visual management and this project prioritization process. It's a collaborative thing led by Dr. Fung, and it integrates with the rest of the team. So everyone knows what the highest priorities are across all the portfolios, and everyone is supporting each other. It also is very much prioritized, because there's be an overwhelming amount of work, as there always is in our business. So this helps us to really effectively prioritize.
Yeah, I just want to emphasize some of what Paul just said. I think it's very important that a lot of this culture that Paul developed rests on some very concrete things. So creating an environment that facilitates physicians being involved in leadership is very key, and that came out of our first Simplexity exercises, and a large part of what Paul has just said is, I can't emphasize enough, help this work. Putting physicians who are leaders together is vital, and each has busy schedules, and if you don't make it a priority, they won't meet together, and they will lose a lot of the value of supporting each other through it. A lot of the buy-in comes from a network they create with each other. Putting them in with the senior administration team was an incredibly, remarkable forward, I think, because that made them, by necessity, engaged and available and able to discuss informally what problems there were. And then it was easier then to convince people that a creative problem-solving method would work better than the traditional ways of trying to solve problems head-on. And then getting physicians to buy into quality tools, again, is facilitated by an environment that allows that. And finally, I think you do need a dedicated person who knows physicians and can relate with them well, that can bind us all together towards common targets, and that can manage these tools for us. So all these items up there, I think, are very key parts of what made us successful in engaging physicians.
The last thing I'll do is on this slide, Min, is just to really a shout out to Dr. Fung and his leadership. With our medical advisory committee, I remember in the early days, it was kind of like policy related discussion. There was really very little, there was no excitement or problem solving happening, and no quality reporting that was occurring before he took over as chief. And now it's so exciting because every meeting is dynamic. All the medical leaders are reporting on really just overwhelming successes and quality improvements. They're talking about the highest priorities. It's a very exciting, and it's such a step forward what our medical advisory committee is doing today than it was doing 5 years ago. But the system and the tools and Dr. Fung's leadership is really pushing us to the forefront of quality improvement.
Very good. So it's like, this is how we do business. It's now, it's on the ground, it's real, and people are working on real things that they're interested in, if I could capture that.
Yeah.
Yeah. So next, now, going back to the first one I showed you, the scatter diagram, which showed a whole lot of problem finders. As Paul said, you need more than problem finders, and here is what the 204 people in the health center looked like. And as you can see, it's there are a lot of people who are implementation oriented, optimization oriented, and conceptualization oriented, but again, a lot of movement toward implementation. A good healthcare situation is a very busy place. Things are happening all the time, but here we have a much more, if I could say, a much more balanced group of people, which was very important because it's one thing to find the problems, it's another thing to solve them and implement them.
Yeah.
And I'm going to ask Paul to speak to this a little bit, if I can. And this has to do with the process.
Yeah. So it's very exciting that we in the last slide that you saw, we had a bunch of implementers. And think about this is healthcare. This is we're dealing with people's very lives and well-being, and we have a lot of amazing people, and they want to go fix things. But we have to make sure that we send them off to fix the right things. You would think that would be second nature, because in clinical decision making, they really try to root out what the core underlying problems are, the root causes. They don't treat the symptom. They treat the underlying root cause. And yet, when it comes to administrative problem solving in the context of healthcare, it's not a natural thing to get to the root cause. Well, creative problem solving makes sure that you do, and it makes sure you don't jump to the wrong solution and create like unintended negative consequences. So this process forces people not to go out and do knee-jerk sort of firefighting stuff that ends up actually harming your organization long term. So back to you, Min.
Very good. Okay, very well explained, especially in the fast pace of the complex environment that the hospital is, but true everywhere. We all tend to jump fast. And this is, if we could just slow down a tiny bit and do a little bit of fact-finding problem definition, we'll probably hit the right problem on the money.
Yeah, remember, Min, Einstein said if I had an hour to save the world, I'd spend 55 minutes defining the problem and 5 with the action, right?
Yep, that's so true. And I think all of us who are listening have been in that situation and understand that. But the teaching that we do in the training is very heavily on saying, don't jump 1 to 8. It's don't jump 1 to 8, and it's triggers in everybody's mind. And that innovation discussion can see, somebody can say to the other, wait a second, are we jumping from 1 to 8 now? And it's a way of helping each other solve problems. It's a tool. Now, the process for healthcare innovation, some of you have seen this before, innovative results come from the content. We got to have knowledgeable people. They got to know what they're doing about what goes on in the hospital. However, we need a process. We need a process for transforming that knowledge into good things. We would never build a car without an assembly process, but many times we try to solve problems without any concept of a process. And the 8-step wheel that we use is a process for helping us navigate. But then we need skills to make the process work, and then we need some tools to be used skillfully, and we have to appreciate each other's style in that not all of us like the same part of the process as others do. Some like generation, some like conceptualization, some like optimization, some like implementation, but we have to work together. Now, 3 process skills that are critical are being able to diverge, able to converge, and deferral of judgment. When we're diverging, when we get together, when we're fact-finding, we listen to everybody. We don't judge them, and we don't cut them off. And your fact may be different from mine. When we got ideas, we listen to each other. And we do that by deferring judgment. We do not allow judgment to get in. But afterwards, we converge together. We bring our judgment, our logic. We listen to each other. And we use something called telescoping, where we telescope The ideas that we picked are the best ones, and we talk about them and talk about them, and sometimes even come up with better ideas. And these are the 3 skills in addition to don't jump from 1 to 8. Those are the 4 primary skills that people will use deliberately to make sure things run well. And here's an example of people who don't know how to defer judgment. And for our people listening today, would any of these not be typical that we've all heard? Now, one of the ones that is most definitely in North Bay is, let's hold a meeting. And Dr. Fung, you're one who really expressed the big one on that. Can you talk about that a minute, what that does to physicians?
Well, one of the key issues of physician engagement is recognizing that they're busy, most of them independent thinkers, independent practitioners, and their obligations to the hospital are only one of many things that they do. But the common tactic that largely kills their interest is that when there's a problem, doctors are trained to essentially solve problems directly and immediately, and the last thing they need to hear is let's form a committee and let's have a series of meetings. That essentially kills most physicians' interest, because largely those committees and series of meetings, in their experience, have led nowhere. And so that was a key part of our, a killer phrase for a physician to be involved is let's hold a meeting and let's go to committee. Or let's try.
Usually implied let's do nothing, and
that implies usually let's take a lot of time doing that.
Yeah. Okay. Yeah.
Okay, so these are things that we encounter, and what we're doing when we do this, we're mixing divergent thinking, which is wide open, and convergent thinking, which is trying to zero in on the best. And when you mix those, it's like driving a car with 1 foot on the brake and 1 foot on the accelerator. We wouldn't do that, and yet people all over the world do this to each other. So I'm going to move on, and Paul, if that's okay with you guys, I'm going to move on.
I just thought of one interesting anecdote here. As CEO, I instituted a policy that people weren't to use the word but, because but, as you taught me, was the ultimate killer phrase, and it basically disrespects what the last person said, and you really want people to build on the ideas and use words like and or building on your idea. And so people really understand that but is a word that doesn't get used in our organization unless it's in the colonoscopy suite.
Very good. Okay. Now, let's go on back to North Bay. The Simplexity methodology is a methodology, and it's designed to be adaptable to any situation that you're in. And North Bay has done a great job of adapting it, and I'd like Paul and Dr. Fung to talk to it. And this is a very particular example.
If we go back to the last slide, though, I just wanted to say that the Simplexity for us has been a evolution. There's a way of doing Simplexity that involves a diverging and a converging path that requires about up to 8 hours of meeting time. And we rapidly decided that was going to be a big ask for physicians. If we want to engage them in that kind of session, we'd have to start modifying. So which I'm going to share in the next few slides, the process that we ended up with. But this particular picture shows the number of people that has to attend a meeting often. This is just a small, I think half of them. And you need to get to a session where physicians are prepared to attend this kind of a meeting and be willing to patiently wait to come to a consensus. And at the beginning, it was a difficult task, and I think we've refined the process, which I'm going to go over, that is still evolving, but has allowed us to engage physicians. And in this particular room, there's both residents, medical students, and actual attending physicians all there and willing to participate in a 2-hour session to try to achieve consensus. And that's it's amazing we've gotten there. So I just want to share over the next few slides what the process that we ended up doing was. So in the initial understanding of Simplexity, for me, there is, as you said, Ben, a pre-consult work that's required. It's an idea generation phase. ideally is done with the group together so they can share why they put the ideas up there. But we simplified that into, why don't we do that as a pre-meeting exercise and involve all the stakeholders in generating that list without them all being in the same room. It made it much more efficient. So when we arrive at the room, we already have the fact finds on pieces of paper ready for the entire group to evaluate with the telescoping method. The telescoping method essentially tries to simplify that list into a smaller number of key facts or issues that need to be resolved first. And that's the initial telescoping exercise that ultimately in 2 phases ends up with a single, the most important issue we need to address first. That gets put onto a different now list, or different spot on the wall. And underneath that umbrella, we regenerate a bunch of ideas about how to resolve that issue. And then we telescope again towards finding the key aspects of that issue that need to be fixed. And we develop an action plan around those items. So that seems like a lot in one slide. So in the next slide, a few slides, I'm going to give you the case study. One of our best Simplexity exercises was we had a very difficult problem, which maybe Paul can articulate better, about recruiting physicians to our community, specifically family physicians. We had a crisis in the community around orphan patient volumes that were becoming excessive. We had retirements of senior family physicians that were making it near crisis level. The city came to us with that problem. How do we get more family physicians here? And this had been a long-standing problem with our own center. We were not quite sure why we were having difficulty filling the gap in family physicians either. Do you want to add to that?
You know what I want to add to, we also had some pre-med, if you will, students, people who are in the later years of their biology. They were actually participants too, because we, in the pre-consult work, we actually identified that we needed short, medium, and long-term interventions to solve the GP capacity problem. And I did want to just to reinforce this adaptation of the problem-solving methodology, as Dr. Fung explained, that happens over a significant period of time. Like it might take a month to do all those steps, and you're only engaging those doctors in the best use of their time during those phases. And a lot of the other work happens, and then they validate it. So this way, we totally respect their time.
Yeah. So building on that, in the pre-consult phase of this particular problem, we had to ensure that we captured all the stakeholders. So we had 25 internal and external ones, and we developed a survey tool with the 4 questions you see there that largely reflected the potential scope of solution that we would need to address. That was sent out over, I think, a 2 to 4 week period, and we ended up with a lot of replies, which if you go to the next slide, you see that allowed us to group those replies into those themes already, and those were pre-populated into the room wall. And when we convened with those 25, I believe it was 25 to 30 stakeholders, they were divided into groups that captured a mix of the different people that were attending. So I think each group had a medical student, a resident, and a physician, and a community member. And each of those groups functioned at the beginning, and this is the telescoping process we're describing now. They were asked to select the top 3. Yeah. So
next
the first step was for the group to try to reduce that big number of items into a smaller number. So each of them was to select a top 3 that they felt. And not only would they select, though, they would have to go up there and discuss, understand, and clarify why they chose that as their top 3. That allowed the group to achieve a commoner understanding of what different people in the room's priorities were. And those top 3 items then, well, the choices would allow items to be reduced to a smaller number of items. Those smaller number of items were reviewed, reworded, done in a way to capture more of the sentiment of the room. And then those now smaller number of items again had the telescoping process. The groups were asked to select what were the top 2 priorities that they identified in the remaining items that were left. and again they were asked to clarify, discuss, defend why they chose to the top, and that left us after about an hour period of time with a single item left, and that is captured in the next slide, which essentially, oh no, sorry, this is the telescoping process with the stickers on the wall, rearranging.
Just one real quick thing on this is I incorrectly described this as dot-mocracy the other day, and it was really a very bad word for men to hear because telescoping, the power of this is you are converging, and yes, you do actually use dots from time to time, but everyone has to explain why they chose what they chose, and everyone has to listen intently to those people. It forces, again, to reinforce the quiet people to contribute, and it dampers the excitable people a little bit so that they aren't overbearing. Both ends really value and contribute to the conversation. So back to Dr. Fung in the next slide.
Yeah, and by the way, we don't use the term voting. There is no voting whatsoever.
Right. Another bad word, see?
That's a very bad word. We basically listen to each other explain, and amazingly, you find out new things you never, I thought you meant this. No, I meant that. Oh my goodness, good. And often some brand new ideas pop out of the discussion. A nice, easy discussion where people are very precise and listening to each other. Now, here's the challenge mapping that happened.
Yeah, so
Dr. Fung, go ahead.
So the final, the item that we arrived at as the issue we had to resolve first, this large group of us, if we were to move forward on this problem, was the center of this, which was how, let's see, how might we support assist physicians in establishing a practice? That was the starting item, and built around that, the group then generated all those items around it. And then again with the telescoping method, they chose from that group, if we go back to the previous one, you'll see the large scatter of items. They selected about 5 most vital issues that needed to be resolved. And that, the next slide, that becomes the action items we had to build actions around.
And these are the 5 that were taken off the map, right here.
That's right. And so around those items, then the group decided one after another which members of the team there and how they would go about trying to act to make those items become actionable steps. And in the next item, we ended up essentially with the way we focused our efforts since that session, and each of those describes a different problem and different way we put support behind it.
So generally, how do we fare in the end of the day? We had a real gap in a large number of orphan patients. Yeah.
Yeah. If you go to the next slide, then those became an action plan. The owners of each task sort of took ownership of those items. They were supported and facilitated to complete them. More ideas that were generated were acted on. And ultimately, over a 2-year period, we ended up recruiting about 15 new family medicine physicians. And our open patient crisis is at virtually an all-time low now. So it was a very successful problem that had been a long-standing one for us that had great impact on the city. And with the city, we ended up building an action plan that ended up solving it largely. So we're well on track to now recruiting the total requirement of family doctors that at the outset of this, we had no idea we were able to do.
Super.
And,
getting the right people, going through the right phases, and working together in collaborative way, and you got something very important done.
And I think one of the key things about the process was that it engaged medical students and residents who largely before were ignored, and they are actually the new recruits, the people you recruit from, and they had no platform by which they could provide the input to the other stakeholders that could actually act on what they thought were they valued most.
If you want to solve a problem, you have to involve the experts who actually do the work in designing a repair for the work. So we really did include everyone, and that's why we had so many innovative ideas. That's why we were successful.
And that was the part about getting the right content and knowledge, and then moving forward. That was a great example.
Yeah. By the way, this particular picture has the mayor of North Bay sitting with two residents.
Oh, very good. Very good. Thank you.
And that is a setting that normally wouldn't have happened in most other problem-solving sessions. So.
Yeah. Very good. And this is the last slide before we get into learnings. Other case examples, if you'd like to speak to those.
Well, cool. Each of the sessions we've had have built on each other. We've gotten we've been able to adapt and be flexible, and a lot of them involve very similar difficult issues that are usually very hard to resolve in hospitals. The clinical documentation and coding accuracy is can be highly volatile with physicians. It's not something they are invested in fixing for hospitals. It tends to be a very punitive kind of system to try to get people to do it. We took a different tactic. We engaged a bunch of stakeholders, held a session to essentially discover what we needed to do to engage physicians in improving that. And we arrived at an action plan that has the top 3 items, and we had outcomes now that show that are really outstanding, considering where we were. We also had an issue with a physician burnout in the emergency room. They were having trouble recruiting. They were not united in the way they recruited. And again, we held a similar exercise that ended up with important key issues they had to resolve. They developed a committee that looked after recruitment and a little bit more consistent messaging to each other through that. And again, they've achieved great success in reversing the burnout issues that they've been having. And we finally reevaluated our medical leadership model, which 3 years later we had to recruit back to, essentially inviting the important stakeholders on how we could make it better. And we had a session that looked at it directly. And again, we have built a number of action plans around what the next model should do, and we're busily acting on it. And it looks like we're going to achieve the better collaboration and a better movement towards an even better relationship between each leader. So again, it's about willingness to use the methodology to try to tackle what at the outset looks like a very difficult issue or difficult problem.
So if I could, and we don't have a lot of time, but I just wanted to highlight the one, clinical documentation and coding accuracy. So all of these are really big successes to really big problems. So in Ontario, in Canada, the way we document, the accuracy and the completeness of the documentation drives the actual funding for the hospitals. And so we had one of the worst basically weighting of clinical activity in the province before this, and we're now one of the very highest weighting for community hospitals that are similar to us, and fully accurate. We used to have a whole bunch of incomplete charts, and it didn't matter what threat, carrot, or stick that you used, you couldn't get that number down. Well, now we have virtually no incomplete charts. We have a massive, probably 200% reduction in overtime for transcriptionists, and our revenue-driven clinical documentation is much higher. And Dr. Fung really reinforced that this was better care, and I reinforced that if we don't have this money, we won't have the resources to provide good care. And then we used the tools, and we really engaged our leaders and medical leaders, and they drove this to amazing heights. So very successful.
Great. I'm going to move on to our next to last slide, which is I asked you guys to put together a compilation of your biggest learnings, and if you could hit some of the highlights here, would be great.
Yeah, I think that, to me, this summarizes what I think it has been the learning experience for me. The biggest, one of the things is the surprising to me as a physician, especially, that it does work. Because physicians are very hard to come to a consensus about anything. And this allows them to understand the problem better, and to understand that the solution is more complicated than they think, and that it does require a number of different action steps that a number of different people have to engage in order to fix these kind of problems. And ultimately, you end up with great outcomes. And each time it works, it kind of recruits a few more physicians to say, actually, it might work more. And it certainly encourages me to try to tackle what I have always considered difficult problems in a different kind of way. Some of the things we've done that I think are essential is to appreciate that stakeholders, you got to get them all in at the beginning. You do have to have pretty comprehensive fact-finding. You do need a skilled facilitator at the beginning especially, and usually largely, and that facility gets better with each session that happens. Initially, physicians will come in with a lot of skepticism of whether this is going to work. So I think you have to respect the fact that that's the way they are, and that if we respect that the amount of time they gave up to be at the meeting and make things efficient, even at the end of these sessions, I don't think they believe that they've done anything. But when they see the ultimate outcome several weeks later that things are happening again, it does get them into the door for the next session better. And the more you do, the better you get at it. And it is actually surprisingly, I wouldn't say, well, it's fun because it's something new and novel, and you get to meet people under a different setting, and you get to enjoy each other's discussions or discuss topics that you normally wouldn't together, and you achieve a better understanding of other people's worlds. So the networking itself that happens in those meetings is almost worth doing them.
Very good. We're in pretty good time. I'm going to ask Bob to take over at this point in terms of any questions you've received that we could answer.
Sure, that was great. We can leave that slide up too. We're starting to get a few questions here. One question that came in a bit earlier was, does North Bay Regional Health Center use a trained independent facilitator during problem-solving sessions to separate content and process?
So initially, we rely heavily on Min and his team for the training and facilitation, but that's precisely what our plan was, is to build capacity in the organization. So we have trained a number of individuals inside the organization. We have a position called Quality Coordinator, which we assign to the different portfolios. So Dr. Fung and his team have a particularly skilled facilitator in this type of problem solving. And I'm trying to make sure that we don't lose that and that we get more and more people trained on this. So in fact, I've engaged Min and his team to come to North Bay to do training so that we can have more people who understand this. And I'm going to do some more and more of that. So yeah, I think ultimately the best learning for me is there's only so much of Min and Bob to go around. You really have to develop the expertise in-house. And I'm really encouraged is that a couple of our really special and important Lynn colleagues have actually gone out and got training as well. So we'll have some company because for the longest time when I say we should be doing creative problem solving on this, I get a lot of very quizzical faces who aren't really excited about the way I would like to approach things. So now we're going to have system-based problems potentially to solve working with our Lynn, and that can be very exciting.
Great. Here's another question, a good question that I figured would come up. How would you compare and contrast this with the lean approach to quality improvement?
Well, thank you for asking that one. It's actually the actual system that we built, and we're very proud of it. We essentially use lean and creative problem solving in a beautiful kind of symbiotic way. One of the things I'll point out is that lean helps you refine an existing process or approach. Creative problem solving helps you think about whether you should be doing that process at all or something different. But it also adds, we call it the fuel. The Simplexity is the fuel for our lean processes. Now, we don't even use the word lean in our organization. That's one of the learnings from the docs is they don't like lingo. That's like a killer phrase to them. So we only talk about continuous quality improvement. And we've actually built a system. That's the special sauce here that we're so proud of, is we've actually melded these two systems together in a way that I think is incredibly powerful. But both are focused on involving people, the right stakeholders, and both are focused on getting to the root cause and not jumping to solutions. And that's what's pretty special. Dr. Fung wants to add to that.
Yeah, I think lean is a quality system, and Simplexity to me is a problem-solving method. And so to me, they very well work in partnership. Our quality coordinators all are invested in both, and you need that kind of a strong team around quality who also know the problem-solving methods. And together, it's a very powerful combined approach to managing continuous quality improvement. Because continuous quality improvement is a process. Lean kind of informs that. We avoid the term lean, but largely to me, it's always been a CQI model driven by metrics. That's the lean process that totally works with me. But lean doesn't inform how do you get to these metrics done? How do you how do you identify the problems and solve the problems that gets these metrics done? And there's some metrics or the metric-driven systems of lean don't require problem solving per se, but it's always there in the background and used as needed. And a lot of problems to me are dealt with or won't be solved by simple strategies to solve them. You might need to look at creative problem solving as a way of tackling them.
Yeah, and also it makes sure that you can properly engage people, because if you just do lean, you're not really getting the hearts of the people, the passion to solve the problems. But if you literally do telescoping, you respect their opinion, and you do it without judgment and using you're actually going to get more sustainable results from your CQI, because people actually have already decided what problems they had a say in what problems you're going to solve. So now they're actually going to help solve it much more readily.
That's great. Somebody wrote, how much time are the providers committing to this work? Are they in week-long events, or are they more like daily improvements or daily sessions?
I was trying to say that, and Dr. Fung can add, is that how we adapted this was don't waste the physician's time, and it's kind of great because we don't waste anyone's time now. It's just that when you have a MIN on site, for example, and people need to have him, and so you can actually learn this, you can only get MIN for a certain amount of time because he's in high demand. So you have to do things over the course of 2 or 3 days in really intense, long sessions. That teaches you how to do it. In the practical sense now, when you chunk up and sequence all the different stages of the model, you can get it done. And by chunking it up, you only have to engage the participants in very focused pieces. Then you move and do a whole bunch of in-between work and then come back. So what happens instead of over 3 days, if you had everyone for 3 days solid, you could solve it. But we do it over a month, and we get the same work done, and we get more done because in each of the times we engaged those people and took them away from their lucrative contract work, it really added value to the system, and they saw the value, and they saw that their time was not wasted.
And largely, each Simplexity session is an event, but we made it very clear that to respect time of physician, to make that event last longer than 2 hours, we would lose physicians wanting to come, and those that came would probably leave. So we make each of those events less than 2 hours. That's part of the, I think to me, the value of a Simplexity session per se is we could tone it into, or we could make it shorter or make it more efficient from a time point of view. The other things that Lean proposes as tools are very valuable too, like value stream mapping and rapid improvement projects. But in attending the hospitals that did those, I recognized early on that those are whole day events usually, sometimes whole week events. And you would only get limited participation of a physician in those events. And largely in those hospitals that did those, you either had to pay a physician for a whole week, and then you get one physician, or you get physicians dropping in for very limited sections of time. So their actual feedback that they were giving was very, very limited, and they didn't own the fix then. They didn't own the solution. So it was trying to get a method that physicians would own the outcomes or the action plan afterwards, rather than see other people resolve the issues into a different action plan that they had no real role in shaping. That's the difference to me between the quality, the tools that are out there. That's different from what we try to do with Simplexity. Simplexity is much more trying to get entire stakeholders engaged, especially in including the physicians.
That's great. We're going to run a little bit longer because I got just a couple of questions left here and a last slide to get to on just from our side. But if somebody's sort of curious how to, he's been exposed to Simplexity before in a different organization, in a big major organization, pharmaceutical company. Just curious on, from your take, Paul and Dr. Fung, on how to best sell or introduce the process into an organization. It seems like people really have to appreciate it, but once they do, once they do it, you sort of get them, but they have to do it first.
So that's a really great question, but it helps if you're the CEO and if you're committed to the process, because even trying to sell starting this in the first place was even a challenge for me. And I pride myself in being a democratic leader, but I've come to the magical formula that I need to be 90% democratic and 10% autocratic. And so in the very beginning, I had to more or less insist that we were going to build, because we were building a continuous quality improvement and lean, and I wanted this at the same time, and I wanted it connected, and I had to force the issue. So I think you need to influence the senior members of the institution and get them exposed, and hopefully maybe they can attend something and learn and then bring it back and get excited about it.
It is a bit of a leap of faith, but I would suggest to people, if you have problems that are difficult, complicated, you never thought that we could get to consensus on, you really have not a lot to lose by looking at different tactics to do that, and Simplexity is one of those. But you do need, I think, at the outset, like we had with Min, somebody who comes in who's able to get a room full of largely skeptical people to suspend their skepticism for a period of about 4 hours, and let's see where we get with this. Yeah. So as I said, you have to try it to see whether it can convince people. The outcomes will ultimately determine whether you ask for another session. That's it. That's what happens.
We've proven that it works, though, back to Dr. Fung's point.
Yeah. Well, last question that I have, and, we talk about interdepartmental cooperation. Could you touch upon how North Bay Health Center kind of enables cooperation between the hospital sort of business development team and its foundation? Is there anything you were maybe doing differently than in other health centers?
Not on the foundation side. No, nothing's ringing a bell. Like, we do have a fundraising corporation that is out there supporting capital equipment purchases, getting tons of donations from our community. And we have a good relationship with our foundation. We have a relationship agreement on how we cooperate together. But it's not necessarily linked to the Simplexity tool. And as far as I know, the foundation isn't using Simplexity, but they invited me to a little session this morning, actually, and I was firing out a whole bunch of convergent ideas for them to consider.
That's good. Well, good. Well, thank you. I think that we're looking at the clock. We're kind of at the end. I want to thank everybody for tuning in. Dr. Fung, Paul, Heinrich, great job. It was a very, just looking at the audience participation, we lost very few people right through the question and answers, so that speaks to the content. And I think hearing how Simplexity is used by somebody other than Min and I goes a long way, and we really appreciate the time you put into this and the time you've spent today, and for creating such an interesting and thought-provoking presentation. It was great.
Yeah, so I think Dr. Fung and I appreciate the opportunity because we're so busy and we're trying to solve so many problems that we rarely reflect and celebrate some of the good stuff. And I think we've done some pretty exciting things with our team here in North Bay, and so we appreciate the opportunity to showcase it.
Okay. Well, I'm going to very quickly do the next slide. I mean very quickly, even though it's like got 8,000 words on it. For people that are interested, number one, attend a workshop. We have lots of them. So everybody who attended today will get this slide deck. These are all on our website. We've got a pile of workshops coming up. We typically do them in Burlington at our location here near Toronto or in Cincinnati. We have a great relationship with some folks at Procter & Gamble, and we use their gym facility quite often to run our workshops, and it seems to be an easy place for people to travel to get there other than coming to Canada. Our next webinar, we haven't come up with a title yet. It's a first for us not to have a title, but we're tentatively scheduling for September 2017. We got some details to follow, and we are carrying on our this pattern of bringing in some guest speakers who are using Simplexity in the work environment. So stay tuned for that. You'll definitely be getting a note from me fairly soon. Any other questions or inquiries, there's my email, Min's email. There's our phone number. We'd love to hear from you, and I'm sure we will hear from a bunch of you. So again, thank you again, everybody, for tuning in. Have a great day, great summer, and we will see everybody again and talk to everybody again in the fall. Till then, talk soon. That's the end.
Thanks.
Thank you.